Okay, I'm gonna let everyone in.
Okay, cool.
Welcome everyone to our talk. My name is student Dr. Addleman, and today Gurmun and I are going to be talking about PM&R and just giving a little introduction to the residency, what it's like, what the career is like, etc. If you have any questions throughout, feel free to just pop it into the chat or unmute or raise your hand, and we can answer throughout the talk, so no need to save it for the end. So just a little outline, we're going to be talking about who we are personally and professionally, what is PM&R, what are some subspecialties in PM&R, what is a lifestyle of PM&R like, and then what we should do to prepare, as well as what the future of PM&R looks like. So just a little bit about me. Here's a picture of me with my white coat. I'm a current second year. I'll be doing my rotations at North Bay. I also am a certified strength and conditioning specialist. Here's a photo of me doing some strength and conditioning classes at Toro, but that's what the CSCS means behind my name. I spent a lot of time with Sports Medicine Club. I actually founded the Sports Medicine Recovery Booth, and so that's something that I'm really passionate about. I also am really passionate about ultrasound and using it as a diagnostic as well as treatment tool. So here are some pictures of me doing that. And I'm, again, really interested in sports medicine. So here's a picture of me on the medical team for the USA Track and Field Junior Olympic National Championships. That was really fun. And then I also have another picture of me doing some ultrasound guided injections on a PM&R rotation for preclinical. So we'll talk more about that later, but definitely something that I highly recommend doing. And then personally, I played softball when I was younger. I had a back injury, and so I started doing some rehab for it. I started getting really into weightlifting. Here's a picture of me with a 500-pound sled push. That was fun. I also do a lot of kettlebell weightlifting now. So here's a picture of me doing a Turkish getup. I also like rock climbing and skiing in my free time. And here's a picture of my dogs.
Hey everyone, so I'm Gurmun and I'm the first year, and so again here, just want to say thanks to everyone for being here today. But yeah, so here you have just me, a little bit about me, a little, we're all in our white coats. And another thing was up here is I'm also involved with SAAO, and this was just from our little like class and kind of info session we did at UC Davis pre-health conference about what's OMM and what we do here at Turo. Yeah, and then just a little bit, I'm an amazing TPL, and also I'm really involved with diabetes prevention program that's here at Turo, so DPP. So there's just a little bit from the diabetes day that we had in fall semester. Also involved in just playing sports for fun. So shout out to our volleyball crew that we had for this fall semester. That was fun. Also love taking photos. I love plants, hiking, all the fun shenanigans. And then, yeah, just simple friends. And then also love baking. So a little mix of everything if I get time to do those things. So, yeah. Alrighty, so I'll just be starting off. We'll get into it about what is PM&R. So PM&R, it stands for Physical Medicine and Rehabilitation. And it's also known as physiatry, so you'll hear them used interchangeably. And this specialty now focuses on looking at like the prevention, diagnosis, treatment, and rehabilitations of disorders that sometimes could just be temporary impingement or functional impairment, but could also be permanent if we're looking at some neurological conditions or if we're looking at long-term issues that are affecting or just movement in general. And the thing is, this field really lines up with like the osteopathic view of looking at the patient as a whole. So that's a really important, right? Taking into consideration that our body is a unit. And it's also patient-centered care and being able to bring autonomy to our patients and helping them regain that sense that they feel might be lost when we are put away with our function and not to our best of ability. It's also known as plenty of money and relaxation. So that's another interchangeable little name used for PM&R. So now we kind of laid out what PM&R stands for, but physiatrists, they'll be working in a variety of roles. So you'll hear some being inpatient, outpatient, also in consulting. And the thing is, this field allows us to use different types of techniques, and you can become experts in which one you prefer. But you use medications, you can use injections. I know our first year just had our first like ultrasound lab. We kind of touched on how you use ultrasound for injections. So it's like one little thing to think about. Therapeutic exercises, cognitive therapy, and adaptive devices. And some of the treatments, as we mentioned, is electromyography, so EMGs, also nerve conduction studies, and musculoskeletal ultrasound. So kind of using that technology that is advancing day to day and being able to integrate that into this field and how we're to provide care is something that's huge, because I feel like as medicine grows, being able to keep up with the technology that's offered can only help improve the care that we're able to provide patients. And again, you're working in a team, so you're able to work with therapists, physical therapists, occupational therapists to like help our patient gain that autonomy and mobility. So now looking at some of these subspecialties within PM&R, we often hear about kind of like PM&R as a general. So now getting into some of the more different parts we can get into. So one of these is known as brain injury medicine. So now this focuses on the prevention of brain injury, as well as looking at kind of the treatment and evaluation and rehab of those pretty much like teenagers and older with certain brain injuries. So some of these, so this kind of goes back into looking at like how we're working as a patient as a whole, patient-centered care. Thing is, some of these injuries could be not only affect like how they are in their brain is like in a physiological or anatomical manner, but also looking at like the educational and the psychosocial consequences this has, and also effects on the central nervous system. So, this subspecialty allows for working in there and being able to help in different avenues and working alongside a different team to provide care for those patients. And again, so this allows more focused in on just kind of like the neuro aspect for within PM&R, which is another great thing, is that you can like kind of take bits and pieces from different like other specialties and combine them into our care. So another one is slightly touched on neuromuscular medicine. So now this is looking at the diagnosis and treatment of any of like abnormalities or issues we run into with the motor neurons, nerve roots, peripheral nerves, or neuromuscular junction and muscles. And these start affecting anyone from general population. And some of the disorders you might have heard of would be like ALS, any types of like peripheral neuropathies, muscular dystrophies, and neuromuscular transmission disorders. So this is where we can use some of the treatments, such as like the conduction studies, to come into play of how we're able to, or EMGs even, to how we're providing care. So you can see that like PM&R isn't just like focused solely on one type of population as well. So like something like neuromuscular medicine allows you to like branch out, focus in on those things. So another one is rehabilitation of central nervous system disorders. So as we talked about a little bit with neuromuscular medicine, we see that when we have any sorts of, we know that like when we have any sorts of changes or impacts or deterioration of our neurons or any sorts of nerves, then affect us in a large manner. And with PM&Rs within this subspecialty of working with central nervous system disorders, we're able to help manage a lot of them. This could range anywhere from spinal cord injury to hypoxic brain injury. So you see the wide variety of cases or sorts of disorders you may be working with. And some of the other disorders would be like disorders of language, speech, swallowing, ALS, neurogenic bladder. And again, you're working with a team to provide care. And I think this again really brings to point how not only would you be considering like how we're helping the patient get through any condition now, but also like how to help them through other portions, right? So we wouldn't just be working with like physical therapists, but possibly if they can, like getting in for like mental health, right? To seeing like, how is this affecting them on that aspect as well. So then another one we know would be pain medicine. So now we're looking at this is kind of broad, but we're looking at diagnosis and treatment of a variety of painful disorders. So some would just be acute or chronic pain, or pain that comes with cancer. And again, this would be within either inpatient or outpatient or even consulting. So it shows that like there is a wide scope that PM&R allows you to go into. Excuse me. And then another would be pediatric rehabilitation medicine. So again, this is a lot of it's providing the same scope of prevention, diagnosis, treatment of congenital and childhood onset physical impairments. And again, this now lets you, if you wanted to, like focus mainly with children within this like specialty of PM&R, you have this subspecialty that allows you to like focus in on that general population. So you're either looking at secondary medical, physical, cognitive limitations. You're also working with a team to help improve function. And this one's a little bit more like near and dear to my heart just because my cousin had Guillain-Barré syndrome. I mess up that pronunciation all the time. And it was actually a PM&R doctor that within this subspecialty really helped her work through and not only help like us understand what that condition is, but help her work through and still like be rehabilitate as she continues to grow up and like kind of learn how to adapt with it. And yeah, another being spinal cord injury. So it's kind of touched on earlier. So this subspecialty would look mainly at treating, diagnosing, and managing traumatic spinal cord injuries and non-traumatic causes of spinal cord dysfunction. And some of these issues might be if you have like MS, I touched on Guillain-Barré syndrome, arthritis, infection, any other sorts of like cancer, any other sorts of like inflammation that could also be affecting spinal cord. And again, you'd be working, get to use equipment, therapies, and also work with others to like help either manage the condition that they're working with or how to like help like build their lifestyle around there. So again, this provides the avenue of like if you solely want to focus in on spinal cord conditions, you have that chance to do so within PM&R. And then also sports medicine. So now you get the chance. I feel like we have a couple athletes in here, those that might be interested, lift and all. This gives you a chance to get involved with that as well. You get the prevention, diagnosis, and treatment of injuries related to sports or exercise. And now you're also working with like, any of those conditions that would be affecting health and physical performance. And again, like, normal, like working with a wide variety of team to help provide that care. So if you wanted to have you had some interest within sports medicine, you get that avenue as well with PM&R. And I feel like just looking at some of these subspecialties shows the wide variety of choices you can go into within PM&R, which is why I love this. So yeah, now we're going to touch on a little bit about like the lifestyle of PM&R, but also so far, were there any questions about the subspecialties? I know we kind of like went through them. If anyone has questions now, feel free to ask. But if not, you can also ask later. Alrighty. If not, then we'll move on to talking about general lifestyle. So yeah. So on a daily basis, I know I touched on how physiatrists can work in a different like range of clinical settings. So outpatient care, so things with sports medicine, inpatient care, we're dealing with strokes, and also a combination of both, right? And I think that having that sense of where you want to work and how you want to gauge your lifestyle really makes this a bit appealing because you have the option of being able to take physiatry the way you want to, based on what you're interested in and what sort of like patient population you might want to work with in the future. And also, you have a pretty you I will some point you end up with a typical and predictable schedule, and that sense of getting to achieve that work-life balance is always really nice. Another thing is this is going to be something that's really team-based, so you get to work with a variety of members within the healthcare team. You know, working with different therapists, you're working with others to like help provide that care. So you're going to be a team player and be able to collaborate to help your patient. And I'm just to touch on a little bit with residency. I know Jennifer will go more into that later, but just like kind of gauge out what you expect for the lifestyle residency. So for PM&R residency, you would do 1 year of like general clinical training. So some might be like internal medicine, family medicine, whatsoever. And then there'd be 3 years of training within physical medicine and rehabilitation. And also, as a resident, your lifestyle is quite predictable, and you end up having a balanced call schedule. So, considering how hectic residency can be, this does provide some bit of a calmer, you could say, sense like what to expect for your residency. And then the salaries, again, I would like to say a disclaimer of salaries is that this is based on just general US and not just like California specific. So it would range, and it could range anywhere from $40,000 to $70,000 a year. This is just going off of what PM&R had to offer. But yeah, just to like touch on a little bit of, because I feel like residency will come first before we get to enjoy the attending lifestyle. And yeah, just touching on salaries a bit again, going off of PM&R. So they went off of all US and said anywhere around like 200, just 270K, 276,000 a year. I was looking at some within California. You can expect around 300,000 or higher, depending on what area you're in, especially from the Bay. Considering everything else, might be a bit higher. But yeah, just to know that like this isn't that salary range coming from PM&R isn't just representative of California only. And again, this really depends if you're in private practice or if you're also involved within interventional practices. Like you get the chance to learn more and like further expand like what treatments or what type of like modalities you want to provide to your patients. So that could also change. And yeah, again, salaries shift depending where you reside. But PM&R is one specialty that pays well, and also you get the chance like if you wanted to, if you can subspecialize in things. So that's always awesome too. Yeah.
Great. So we'll transition into the next section. And if you have any questions, feel free to send them in the chat or raise your hand. Happy to answer at any point. So I'm going to start with talking about what we should do to prepare for PM&R. And there's a lot of things you can do. So these are just some recommendations that I would have. But there's a lot more that you can do, and you don't have to do all of these things. So the first one would be to join all the PM&R organizations. There's a lot. There's PM&R, which is the American Academy or American Association of PM&R, which is basically MDs and DOs. And then there's AOC PM&R, which is more the osteopathic group. And that is where our club is basically associated with AOC PM&R. There's specific ones within each subspecialty. I put some of the sports med ones here. So there's AMSSM, there's ACSM, there's AOASM. There's also pain medicine ones. There's the Association of Academic Physiatrists, which is more research focused. They actually just had a conference, I think it was last week. So they're a good group as well. And Representation in Rehab is a newer group, and it's mostly made up of residents as well as students and some physicians as well in physiatry. And they basically are trying to spread the word about what PM&R is and increase the diversity of the group. So all great groups that have a lot of resources that you can utilize along your path, and just learn more about PM&R if this is something that you're interested in. You can also participate in club events. So again, we are AOC PM&R at Toro. Gurmun and I are both in that club. If you need help getting into it, you can join on campus groups, but there's also a Facebook group that we can add you to. So just contact us at any point. We can add you to it so you can kind of know a little bit more about what events we're having within that club. And then you can get in touch with a mentor. So I put both of our pictures on here. We are both happy to answer any questions that you may have. But there's also some amazing third and fourth years that have been fantastic resources for me, for both of us. And so I didn't want to put their names on here, but if there is a third or fourth year in the Zoom, you can feel free to drop your contact info in the chat if you want people to contact you with questions. But again, getting in touch with a mentor is really helpful, especially when you're trying to figure out rotations and any other specifics within PM&R. Really helpful to have that. You can learn more about PM&R through any of the groups that I already talked about. I really like AAPM&R's website. They have a lot of specific questions that can answer just anything that you have that you're confused about within PM&R. I would recommend going to a PM&R conference at some point. You don't have to do it right away. You can wait until third year to do it, but going to a conference like this can really help connect you with physiatrists as well as residents. You can get to know other residency programs and just kind of learn more about PM&R at these events. You can also do research. I put a question mark because you don't have to, but a lot of PM&R residencies will have you do research. So getting into it early, there's definitely no harm in doing that. And then if you don't want to do a big research project, you could do something like a case study for a physician. You can present at a poster. You can present your poster at a conference. And that's just a great way to show your passion for PM&R, as well as, getting some research in, since some PM&R residencies do like to see that. Again, not required, but it can be really helpful. Next is doing a PM&R rotation. So I was able to do a preclinical rotation through an elective. So I did it between first and second year. And that's basically, you can start doing the PM&R electives as early as the summer between first and second year. I am still a second year, so I haven't done a lot of rotations in PM&R, but here are just some recommendations that I have or that I've heard for doing these rotations. So you'll definitely want to explore all the different settings, as many as you can, when you're doing your rotations. So you'll want to see a little bit of outpatient, some inpatient, MSK, neuro rehab, adults and peds. You just want to see as much as you can, because even if you're interested in one specific subspecialty, you will be experiencing all of them in residency. So it's good to know that this is really what you want by doing as many rotations in as many settings as you can. You can find these rotations through school or through outside connections that you may already have. You'll want to make sure that you review MSK and neurophysical exam skills before your rotations. If you're a first year, you won't know them yet, but you can get some resources from someone else so that you have those. I put a picture of a reflex hammer. You'll want to have one when you're on rotations. You can also take this time to learn about rehab protocols and what the other professionals are bringing to the table. So Gurmun really emphasized this a lot, that it is a team effort for sure. And so it's good to know what the difference between physical therapy and occupational therapy is. And everyone who's going to be on that team in the hospital, in outpatient or in inpatient. So it's good to kind of study that up a little bit, because you will be seeing them on rotations. This is a good time to try to get a letter of recommendation, but again, this sounds cheesy, but the primary focus really should be exploring PM&R. You want to make sure that this is what you want to do, and that's why it's so important that you see multiple settings, even if you're not extremely interested in one of them. And just because you don't like one area of PM&R, it doesn't mean that PM&R isn't for you. It just maybe means that maybe you don't want to subspecialize in that, but it's good to know what you're interested in. I also put some other pictures here. So I used this Pocketpedia book when I was on my rotation, and it was extremely helpful as a resource. I just kind of read it whenever I had free time. And then here's a picture of SonoSim. I'd recommend reviewing some of the ultrasound modules that they have on there, just to review, because I did a lot of MSK diagnosis when I was on my rotation. Excuse me. And so it's helpful to review those modules beforehand. I'd also recommend doing a non-PM&R rotation PM&R has a good reference here. It just talks about some other specialties that can really add to your PM&R skill set. So even if you don't get a PM&R rotation, you could do maybe a radiology rotation, and it can just provide a lot of those skills that you'll need in PM&R. You can also volunteer within PM&R for various groups like adaptive sports or Special Olympics, through sports medicine recovery booths, or through free clinics. There's a bunch you can do, so this isn't a full list. Sorry about that. Are there any questions so far? Okay, so next we'll talk about the future of PM&R. There's a lot within the future of PM&R. Here's just some things that I'm really excited about. So one of them is wearable technology. There's really a big future here, where athletes and everyone else can benefit from having a view of your recovery and getting actionable insights about how specific activities can affect recovery and performance potential. And this isn't just a sports medicine thing. This is really growing a lot. Even in cardiology, there's a lot of use. And we're getting more and more accurate data. So we have like this is a picture of Whoop, but there's like Aura rings. There's a lot of information you can get within wearable technology. It's definitely going to be the future. So get ready for it. Next, we have MSK Neuro ultrasound diagnosis. So there's a lot more technological advances nowadays for use of handheld ultrasounds for ultrasound diagnosis. So here's a picture of one that actually has a linear and a curvilinear transducer. And it's about $5,000, which is actually really reasonable for an ultrasound. So there's definitely a future in this. You can identify tears, so even interstitial tears, which usually you can't really see that well on MRIs. Before you even order an MRI, you could show the patient right then and there. You can really validate them and say, hey, I hear you, I know you're in pain, and I can actually see the tear right now. So instead of telling them to go wait for an MRI, come back in a month, or even 2 3 months, you can give them that validation of it's reasonable that you're in pain because I can see a tear right now. I'm still gonna have you get an MRI to confirm, but I can see it. So it really validates them and gives you an actionable plan for the next steps. We already kind of talked about this, but there's a lot of ultrasound guided procedures you can do. Here's a picture of ultrasound for the shoulder, and then here's one for the knee. This is a needle. And so you can do burst injections, joint injections into tendons. There's a lot you can do. Nerve blocks, hydrodissections. So that's definitely a big part of PM&R, and it will continue to be. We also have biologics injections, so PRP. This is platelet-rich plasma. They're becoming really popular. The evidence is a little conflicting right now, but there's lots of potential with more studies and better clarity on exactly how to use it clinically. There's some clinical protocols that aren't as effective and some that are, so it makes the research a little tough to tease through. And then hyaluronic acid is also used as an injectant for osteoarthritis. So these things will continue to be talked about and used for a while. There's also gait analysis. This can be helpful injuries with otherwise unknown etiology. Honestly, we can get really complicated with this, but the less tech can be just as effective as more tech if you just know what to look for. So I've seen you could set up an iPad on a tripod and record someone running. And as long as you get a good view and you know exactly what angles to get, you can actually get a lot of information with very low tech. And we have more research now, and we'll continue to get more research that will guide clinical protocols and have actionable drills to give to patients. There's more concussion research nowadays, and so the research will continue to guide clinical protocols for concussions. And then osteopathic medicine. We talked about this a little bit, but osteopathic medicine and PM&R go hand in hand. It's a very DO-friendly specialty, and you actually have so many musculoskeletal and palpatory skills. They give us more diagnostic and treatment tools for patients. So it can be a real advantage to be DOs in PM&R. Any questions about any of that before we do a little fun MSK ultrasound demo to finish off the presentation? Okay, well, we'll go ahead and get started. Again, if you have questions, feel free to send them. One sec. Okay, so I know that the first years just got their first ultrasound lab. Yay. I hope you're excited to review those skills and learn some more. This is for a knee injection. This is actually straight from SonoSim, so you can watch this module whenever you want. But we're going to be talking about knees. Knee injections are really probably one of the easiest joint injections to do. I got to do probably 10 of them during my preclinical rotations. I got to see a lot more, probably like 50. So there's a lot of potential here. Really good for osteoarthritis and just any kind of pain syndromes in the knee. There's a lot that you could do, but mostly we're doing it for osteoarthritis because we're getting it into that joint capsule. So just some review for ultrasound. In this picture, you could see that the ultrasound is placed vertically, which is also called longitudinally in ultrasound words. And the indicator is on this side, so it's pointing towards the patient's head. This is really important to know because that determines what view you have on the ultrasound. So just a review, that is pointing longitudinally. And the indicator's here, so that means this is towards the head. And then the top part of the screen is always more superficial, so it's closer to the probe. The bottom part is always deeper. And so actually this is bone here. I'll talk about that in a bit. But this is skin up at the top. So if the indicator is pointing towards the head, and this is where the position of the probe is, we know this is a bone right here, this bright white line over the black space, because ultrasound doesn't go through bone. So we know that this is going to be the femur. And we just know that just because of the way that this is positioned. We know that this is the patella because it's the next bone down. It's the first bone you hit. So again, since you can't see through bone, you know that that's got to be patella. And so this is basically the joint right in here. So we have femur, patella. Okay. Up here we have skin. We have subcutaneous tissue right here. It usually kind of looks like this. It's like fat tissue and various other things. There's fascial lines, etc. And then here we have a tendon. It's already labeled for you, but it's the quadriceps tendon. And that makes sense because it's the quad muscle and it's coming together, big quadriceps tendon. And then it's going to go over the patella. It kind of includes the patella. And then it goes into patellar tendon down below. Okay, so we have quad tendon. And then here we have some fat pads that we don't really talk about in anatomy, but are very important when it comes to injections. Fat pads are super painful when you inject into them. They have a lot of nerve endings, so you really kind of want to avoid injecting into these. So that's why they're important, and we can see them really well on ultrasound. That's one of the reasons why ultrasound guided injections are so great, is because you can see when you're in the fat pad and you can avoid it, making these injections way less painful. And you'll know that you're in the right spot because you can actually see where you're going. So femoral fat pad, it makes sense because femur's right here, it's in front of it. So it's anterior to it, prefemoral. And then here we have suprapatellar. If this is a patella, it's right on top of it, or superior to it. So kind of makes sense. But these are the two fat pads that we're going to be thinking about. And then here we have a synovial recess. This is the suprapatellar synovial recess. And so what's kind of weird about these and not really intuitive is that you actually inject kind of all the way up here. You would do it from the lateral side, but you inject from all the way up here. And on the anatomy picture, it's up here. So that doesn't really make sense if you want to get it all the way down here, right? Here, I'll go back. So right here, that's where you want to get it into. But if you're trying to inject right into there, there's a lot of stuff there. We got LCL, there's a lot of ligaments there. It's pretty painful to try to just go straight into the joint. So we don't really go this way, but if we inject all the way up here, how does it get down here? Well, the suprapatellar bursa is not really a bursa. That's why they call it a synovial recess here. It's actually an extension of the synovial sac that goes all the way up, and it's deep to the quadriceps tendon. So what's cool about that is we can inject all the way up here and kind of avoid a lot of the painful stuff, and then it goes all the way into the joint. So that's kind of the overview of this view. Happy to answer any questions if anyone's confused. Okay, so I'll move on to the next view, and then we're going to talk about the injection protocol. So now we're in a horizontal view, otherwise known as a transverse view in ultrasound words. The indicator is pointing laterally. Usually in ultrasound, you aim it at the patient's right. But when you're talking about MSK, you can kind of pick whatever you want, because you can either point laterally or medially. You basically just want to know which one you always pick. The reason is you want to know where your needle is coming from when you're doing the injection. So if we know that the needle is coming from laterally, we know that the needle is going to come from where this dot is. I'm going to come through and inject. If we were to point the indicator on the other side, the needle would come from this way. So that's why you just want to know where to expect your needle. So again, we're talking transverse view here. Up here we could see the muscles because we're pretty superior. So we're before the quadriceps tendon basically. And we have subcutaneous tissue up here. We have rectus femoris muscle. We have vastus intermedius. We have vastus lateralis, and we have vastus medialis. And so this is kind of the view if you were to move more inferiorly. This is where you would be thinking about doing your injection. And this is actually kind of the view you would see. But you would see more, you would see a big tendon, and then you would see if there's an effusion in the joint, so like if there's joint swelling, you would see a big black spot, and that's where you would be aiming for. And so now we're going to watch a video on what the injection looks like with the needle. And let me know if you guys can't hear it, but you should be able to hear it.
Next, we're going to review injection of the knee. Before we get started, keep in mind that this is just a demonstration, and normally these are performed under sterile environments with betadine and cupping the area properly. This is just an idea to show the physician exactly the approach that we use in doing injections with the proper needle placement and approach. The most common target that physicians typically inject the knee joint is the suprapatellar recess or bursa. We begin by placing the transducer in a longitudinal plane with the end of the transducer just above the patient's patella. Next, in setup for the injection, I'm going to rotate my transducer to cross-section. And here we can visualize the physiologic.
So like I talked about before, there's basically you see femur, and you'd see this black hole if there's an effusion. That would be the fluid that's in the joint, and so you would want to aim at that spot.
Fluid of the suprapatellar recess, which is the band of darkness above the cortex. This will be the target site of our knee injection. The proper landmarks associated with a knee injection are palpating the iliotibial band, which is a structure that runs down the lateral thigh, and in between the iliotibial band and the vastus lateralis is a soft spot, palpated right here. The needle is inserted in the soft spot between the iliotibial band and the vastus lateralis in a direction directly beneath the center of the transducer to ensure an accurate localization.
So just to be clear, you could kind of see his needle over here. He's actually pointing it pretty horizontally. So a lot of people think that just because the needle's coming from diagonal in the ultrasound that you need to go diagonal, and that's not how it works. The ultrasound it's in 3D space and it's giving you a 2D image, so it's not really that simple. You're usually actually going straight from horizontal on the side of the knee, right above the IT band. You're going straight horizontal, and you'll find the joint. So now we'll see an example of an injection.
The needle will be guided into the suprapatellar.
That's the needle right there.
And lidocaine is typically injected to ensure proper location. you'll see the bursa expand.
So you can see as the fluid's going in, the bursa is expanding, and so you know it's going in there. And then sometimes you can even see the fluid actually shooting all the way down, and you can see it in the joint later. And so that is our talk. Hopefully you enjoyed the ultrasound demo as well as our talk, just going over the basics of PM&R. If you guys have any questions, we're happy to answer them now. But otherwise, thank you so much for coming. Here's our emails. You can contact us anytime.
Hello, thank you so much for the presentation. You mentioned preclinical rotations, and if there's anything I want to do with my summer this year, it is like get involved in PM&R like and see it firsthand because I love the idea of it. I've never actually done it. So did you have like a personal connection that you like found this clinical rotation, or are there like avenues that we can go to find how to experience it this summer?
That's a great question. So basically the elective that I was talking about was, you can find it on the electives list on the website somewhere. But it's basically an opportunity for you to do as many hours, as much as you want, anywhere you want to go. The difficult part is if they haven't been associated with Toro before, you have to do paperwork that allows them to be in the system. So it's better to start early if that's what you're going to do. So to answer your question, I knew someone personally who knew someone who knew someone who was really good at ultrasound guided injections. And so I was able to get involved with his practice. But he really enjoyed teaching students. And so I'm sure that he would be open to having other students join as well. His name's Dr. Alberto Pinero. I can send you some information to help you get that sorted out if you want to work with him and his setting, which is mostly injections in MSK. But basically the easiest thing to do is they have a spreadsheet within preclinical, or like the CED department. They have a spreadsheet of every doctor that's been affiliated with Toro before, and you might be able to find a PM&R doc through that. So that is a great resource. Usually they're local, but sometimes they're kind of far. Just kind of varies on what you're looking for. But that would be the easiest path. So you don't have to do any paperwork. It's just already done. You get in contact with them. If they're available, you do it. Perfect. And then you have to like track your hours as a part of the elective and do like some journal entries. So that's the easiest way. Then the second way would be if you know someone, you have to contact them early, get them to fill, so like in the next month or two, get them to fill out the paperwork, which is kind of a process because they have to do a little bit of work in the paperwork. So, they have to have the time to do that. You have them fill out the paperwork, you submit it to the clinical education department, and then they'll put them in the system, and then they'll send you an approval. But they take forever to do that. And so what I'd recommend is send it in. I actually got approved for mine after I had already started. But it was like a week after, so it didn't really matter that much. But there are some people that don't get approved, even though they do the elective anyway. But the reason you want to go through the elective is because rather than just shadowing, is we have malpractice insurance through Toro that we pay for. So if you do it through the elective, then they'll be able to let the physician will allow you to do things like you can actually do injections and things like that and work with patients more because you have malpractice insurance. But if you don't do it through the elective, then it's on the doctor. And so they don't like that. So that's why you want to go through the elective. Like I said, it's a little bit of a process, but I had a lot of fun and it really solidified my interest in PM&R. So
awesome. And I guess since you did it with your doctor, he's already in the system.
Yes, so it'd be easy to work with him again, for sure. And I could send you more info if you just send me an email, and I'll give you more info on that. But
cool, awesome. Thank you.
Yeah, if there's someone else that you can do the same thing.
I don't know anybody personally.
Yeah. You can also what you can do is you can maybe contact UCSF or some other group that has a big hospital system where they might be able to help you get connected with their PM&R faculty,
Sweet.
or just any doctor that works within their system. Unfortunately, Toro doesn't have like a PM&R department or like an affiliated hospital that we work with, which is why it's a little harder. But you can always just reach out, and most people, even if you don't know them personally, they're usually pretty nice, and then a lot of people are open to having students.
Sweet. Thanks so much.
Yeah, you're welcome. Any other questions? You're welcome. Thank you for coming. Zoom. But thank you so much, everyone, for coming. Feel free to email us if you have any questions.
Yeah, thank you. And I'll stop the recording too then.